Hey everyone! Dilated cardiomyopathy, or DCM, is the most common cardiomyopathy in dogs and ranks second among acquired heart diseases in this species. In today's video, we're diving into a recent retrospective study specifically looking at anesthetic management and complications in dogs diagnosed with a DCM phenotype. Unsurprisingly, there's widespread concern among veterinarians that DCM increases anesthetic risks in dogs. And as a result, many dogs with DCM needing anesthesia are referred to specialty centers. Interestingly, before now, no studies had specifically evaluated anesthetic risks in dogs with DCM. To address this gap, researchers from Texas A&M reviewed records of dogs anesthetized at veterinary teaching hospital between 2010 and 2024. They compared 30 dogs diagnosed with DCM to 30 matched controls without heart disease, carefully examining anesthetic management and complications. Control dogs presented during the same period and were matched with DCM cases based on age, breed, and type of procedure. So, what did they find? The most common breeds included Doberman Pinschers, Labradors, Golden Retrievers, Great Danes, and mixed breed dogs. Careful matching ensured no differences existed between groups regarding age, breed, sex, or body weight. Additionally, there were no significant differences observed concerning the reason for anesthesia, ASA classification, duration of anesthesia, comorbidities, or blood work results. Out of 30 dogs with DCM, 22 dogs, or 73%, had an occult form, 6 dogs, or 20%, had an equivocal form, and only 2 dogs, or 6.7%, had overt DCM. In their occult or preclinical stage, dogs have no obvious symptoms, even though echo clearly shows signs of the disease, like a dilated left ventricle and reduced fractional shortening. Think of this as similar to stage B2 in myxomatous mitral valve disease. On the other hand, dogs with overt or clinical DCM show clear signs of congestive heart failure, such as cavitary effusions or a history of cardiogenic pulmonary edema. This stage closely corresponds to stage C in mitral valve disease dogs. Finally, equivocal DCM represents a borderline or gray zone category, where dogs have some echo abnormalities, but these changes aren't quite severe enough to definitively confirm the disease. This is crucial information to keep in mind when extrapolating study results to your clinical patients. As you can see, only 2 of the 30 dogs had overt DCM requiring heart failure medications such as diuretics. Most dogs in this study were asymptomatic and diagnosed solely based on poor contractility visible on echocardiography. At the time of anesthesia, 23 of the 30 DCM dogs were receiving pimobendan. Anesthetic protocols differed significantly between groups. For example, dogs with DCM were less frequently pre-medicated with dexmedetomidine, likely due to concerns about reducing cardiac output, and they were less often induced with propofol. Instead, anesthetists favored induction agents like etomidate and midazolam for their cardiovascular sparing effects. Dogs with DCM also received lower IV fluid volumes in total, 6 ml per kg versus 14.3 ml per kg in controls, although no significant differences were identified in fluid type, frequency, and volume of bolus administration or use of anticholinergic or antiarrhythmic drugs. However, dogs with DCM were significantly more likely to receive dobutamine as a positive inotrope. Interestingly, Overall complication rates, including hypotension, hypothermia, and post-op recovery issues, did not significantly differ between dogs with DCM and controls. That said, dogs with DCM were more prone to cardiac arrhythmias during anesthesia, occurring in 11 dogs with DCM compared to only 3 in the control group. In the DCM group, 3 dogs experienced single VPCs, 2 had single VPCs with second-degree AV block, 2 had ventricular tachycardia, 3 dogs experienced atrial fibrillation, and 1 dog had first-degree AV block with a right bundle branch block. Only 1 dog from the DCM group required oxygen supplementation during the first 24 hours post-anesthesia. No anesthetic-related deaths occurred in either group, suggesting careful anesthetic selection and monitoring can achieve outcomes in dogs with asymptomatic or cold DCM, similar to control dogs without DCM. However, it is essential to recognize that this study primarily included dogs with a cold or mild DCM, meaning the results may not apply directly to dogs with severe DCM or heart failure. So what's the take-home message? First, dogs with a DCM phenotype, especially asymptomatic ones, can safely undergo general anesthesia with outcomes comparable to control dogs without DCM when careful anesthetic protocols and intensive monitoring are employed. Second, avoiding Dexmed and favoring induction agents like etomidate or midazolam may help preserve cardiovascular function, although future prospective studies are needed to conclusively determine if specific protocols or drugs are superior. Lastly, if you're anesthetizing a dog with any form of DCM, be prepared to manage arrhythmias and maintain adequate cardiac output using positive inotropes like dobutamine. Keep in mind this study's relatively small sample size and retrospective nature means definitive conclusions can be drawn. Yet it still provides valuable insights and is currently the largest of its kind addressing anesthesia in dogs with DCM. Overall, while DCM certainly warrants extra caution, this study reassures us that carefully planned anesthesia in dogs with occult DCM can indeed be successful. Keep these insights handy next time you're prepping a DCM patient for surgery. And thanks for tuning in. I'll see you next time. Bye-bye.